Well, the rationale for doing this study is that there's very limited data, actually. There hasn't been a study that has evaluated the outcomes of transcatheter mitral valve replacement procedures in patients with valve-in-valve or valve-in-ring or valve-in-MAC. We know there are registries that collect data on those procedures, but there has not been a prospective study. So we decided that it was time, and this is a physician-sponsored multi-center prospective clinical trial that is evaluating the outcomes of these patients in these three types of patient populations: the mitral annular calcification, MAC, 30 patients in that arm; the valve-in-ring, 30 patients; and valve-in-valve, 30 patients. So a total of 90 patients were enrolled. So we're using balloon expandable valve, particularly the SAPIEN family of valves. When I wrote the protocol back in 2014, the SAPIEN 3 valve was not commercially available. Excuse me. So the product that we had at that time was the SAPIEN XT. So the version 1 of the protocol was the SAPIEN XT. Only 2 patients were treated with that technology in 2015 when we started enrolling, and soon after the SAPIEN 3 became available, that has been the valve of choice. So it's mostly a SAPIEN 3 valve study. This is a prospective enrollment of 90 extremely high surgical risk patients with symptomatic severe mitral valve disease due to severe calcification. Those patients were assigned to the native valve arm, MAC arm, or patients with failing surgical rings. They are in the valve-in-ring arm, 30 patients, or patients with failing surgical bioprosthesis, so patients who had a prior replacement and the valve is no longer working. Those were assigned to the valve-in-valve arm. So we presented today the 30-day outcomes of the valve-in-ring and the valve-in-MAC arms. The valve-in-valve arm is going to be presented at AHA. So the findings today in the valve-in-ring were that we saw a low in-hospital and 30-day mortality, lower than it was predicted. These patients had a predicted risk of mortality of 9%, and with transeptal valve-in-ring, all these patients were treated with a transeptal access, which is much less invasive than surgery. So with transeptal valve-in-ring, the in-hospital and 30-day mortality that we saw is 6.6%, so lower than expected, so low mortality. Also, the complications were lower, relatively low for a new approach, and the endpoints were technical success at exit from the cath lab and procedure success at 30 days. Those endpoints are said in few words, but they are a composite of multiple components to achieve that technical success. So the fact that you put a valve, it doesn't mean that it's a successful procedure. So it's very strict criteria. There has to be a single valve in the proper position with good function, no significant gradient. So we had cutoffs, and the patient must leave the cath lab alive. So technical success in the valve-in-ring was achieved in 70% of the patients, so it's most patients, and it was limited by the need of second valve in 6 of those patients, or 20%. So once you need a second valve, you no longer meet the definition of technical success. But what is important to mention is, one, that the need for second valve happened early in the experience of the operators, and with changes in the technique, we were able to improve that. And second, the outcomes of patients who required a second valve, they were actually good. All those 6 patients were alive at 30 days, and they all met the very strict criteria of procedural success at 30 days. So what would be interesting to see is if they meet the criteria of patient success at 1 year. But second valve was not associated with a poorer outcome. So those were the main findings in that arm. Different than the MAC arm. The MAC population is a very, very high-risk patient population. No matter what you do or you don't do, they are high risk no matter what because of multiple comorbidities. And even before they develop mitral valve dysfunction, they already have increased risk of cardiovascular disease and cardiovascular death and all-cause mortality. And even TAVR studies are finding that the presence of MAC when a patient comes for a TAVR, the presence of MAC calcification in the mitral annulus alone is it correlates or is a predictor of poorer outcomes. So in general, it's a very high-risk patient population. In addition, the procedure is a lot more challenging. So technical success actually wasn't too bad, was 73%, maybe a little bit higher than the valve in ring. There was less need for a second valve. But the technical success was primarily limited, by other complications that were seen. Not all these patients were treated with transeptal access, the less invasive approach. Half of them were less invasive and half of them were open. And there were deaths. There were 5 deaths. So the overall mortality, just to wrap it up, the overall mortality was 16.7%. So it's higher than the valve in ring. There were other differences, but I think the take-home message is, mortality has improved compared with registries, but we still need to do a lot of work in refining the patient selection and refining the techniques of both transeptal valve in MAC and transatrial valve in MAC. I think that with these initial results in the valve in ring group, if you have a patient who has severe symptoms and severe disease and is a high surgical risk patient, I think it's reasonable to offer them a transeptal valve in ring. And if we are going to move into that direction ever, which I think we should, that means that we now need to start working on what is going to be years from now. For example, I would invite or ask surgeons to please, if they are going to do a surgical repair now, I would invite them to please consider a surgical ring that can be treated with a valve ring in the future, because chances are, if the patient lives long enough, the patient will need a reintervention years from now. So if we pick a ring, a very rigid ring, those are not good for valve ring because it will not allow the valve to expand. Or if you pick an incomplete, let's say a band or a very flexible band, doesn't have the anchoring force to allow a valve ring procedure safely. So I would recommend that if you need to put one ring now, pick the ones in the middle that are semi-rigid, that are complete, the ones that were used in this trial, so that we can treat them in the future with a valve ring. So I think we should have an approval for valve ring, hopefully, and we should see a change in current practice in selecting rings for operations that need to be done now or in the near future, selecting rings that are going to be amenable for valve ring years from now.